I'm Christian Funck-Brentano. We will be discussing today the new implications of the toxicity of oncology drugs on the heart. And with me to describe this topic are two experts of the field, Dr. Alexander Lyon from London and Dr. Teresa Lopez Fernandez from Madrid. So we have a very large set of questions, but first I'd like to ask you, Teresa, and also Alexander, what is the scope of this new domain which is called cardio-oncology?
Well, cardio-oncology is a new subspecialty in cardiology, and the reason to need cardio-oncology is because cancer treatment have markedly decreased cancer-related mortality, but these cancer survivors experience a great increase in cardiovascular mortality in the years after they cure cancer or they receive cancer treatment. Thus, cardiologists, we need to focus not only to treat chronic cardiovascular side effects, but we need to move to focus to more preventive strategies to try to decrease the cardiovascular risk of cancer survivors.
So I agree. We now know that there are almost 18 million people in Europe who've had cancer, and many of them are getting older. My oncology colleagues say we're curing heart disease, so patients are living after heart attacks to then develop cancers. They have an aging population, so it's changing the demographic. We've sort of got older people, lots of existing cardiovascular risk who may be more vulnerable to short-term toxicities. And then we've got the younger population, children, young adults, where they may have 40, 50, 60 years of life ahead of them, and therefore cardiotoxicity is a growing issue.
In fact, the risk of heart failure in a children survivor for cancer disease is 10 times increased above the risk to suffer heart failure after a heart attack, for example.
And we have this sort of issue with old-fashioned chemotherapies, anthracyclines, which we know are cardiotoxic, and then all these new blockbuster cancer drugs, which are very effective on cancer, but are poisoning the heart.
I was going to say that most of the problems have emerged because we have a large development program for new anticancer drugs, and that the old problems that we had in the past are now viewed somewhat differently from what they were before. And in that respect, Alexander, the anthracycline problem has changed over the years. I mean, the view on this topic from 10 or 15 years ago has changed from our view that is currently influenced by novelties. Now, if you had to summarize the novelties in terms of oncocardiology respective to the anthracycline compounds, but also other anti-cancer drugs, what would you say has changed recently?
Well, I think for anthracyclines such as doxorubicin and epirubicin chemotherapies, previously the cardiology community and medical community had waited for the problems to develop, clinical heart failure to present. And at that stage, it's a very challenging condition to treat, hence the label of it being irreversible, highly toxic, and often sadly fatal. Now we're implementing surveillance strategies so that you can pick up toxicity earlier in the people who get it. Not everybody has the problem, but if we're using biomarkers such as troponin, echocardiography, and including novel, more sensitive echocardiographic parameters, if we pick up the problem early, we can prevent it. So rather than having a response or rescue mode, we can actually have a prevention strategy. And there's good data that prevention, personalized cardiac protection and prevention, can at least improve surrogates. We're still waiting for the hard clinical evidence that would form a guideline, but at least we've got very encouraging signs that we can intervene with modern heart failure therapies and make a difference.
Yes.
Do you agree with this?
Yes, completely agree. I think that today it's not possible to take a decision about cancer treatment without to balance cardiovascular risk and cancer risk mortality and recurrence, of course. And the aim is not to avoid potentially cure medication, but to try to reduce or to minimize cardiovascular side effect with a preventive strategy.
I see that during the session that you attended, Dr. Rosano discussed the endpoints of clinical trials and drug development and how to detect, not in the sense of clinical practice, but in the sense of how to document precisely the extent of cardiac damage when new oncology drugs are being developed. Would you like to comment on this detection in clinical trials and endpoints, how to design a trial of an oncology drug and make sure that cardiotoxicity, if any, can be detected early? Is that just the same as in real life in practice?
So I would say it partly depends on what the mechanism of action of the drug is, because there'll be some drugs where we're more suspicious of cardiotoxicity versus others where we're less concerned overtly. The second thing is, what is the cancer that's being treated and what's its current prognosis? Is it metastatic disease, in which case we'll tolerate quite a high threshold of cardiotoxicity, or is it an adjuvant treatment where actually many people are being cured? And then you have to define what your risk is and apply it. And I am involved in adjudication for cardiovascular events for some oncology trials, and I can tell you it's pretty rudimentary by modern cardiology standards. And I agree that they have a lower threshold for licensing through the FDA and EMEA for an oncology drug. It's often about progression-free survival from the disease rather than hard clinical endpoints, which we're used to in the clinical cardiac community.
And finally, and very briefly, if you had, Teresa, to organize a cardio-oncology department or service, what would be the 3 or 4 main points that you would think of recommending?
Well, the main thing is to look for professionals that are interested in cardio-oncology to reach a good compromise to work on it. But I think that one important issue in cardio-oncology is when we review literature, there are many definitions of cardiotoxicity, different levels to reach the diagnosis of cardiotoxicity, and we need to work to unify the definition of cardiotoxicity.
And I think it's very critical to have a partnership with the oncologists. This isn't us alone, it's together with the oncologists to give the best outcomes for their patients.
And of course, it's really important to work between hospitals because cancer treatment is really complex and it's difficult to collect a great number of patients that were on the same cancer treatment to reach evidence about protection.
Okay, well, thank you very much. And if I can summarize or try to summarize the key points that you have just mentioned, the scope remains large and probably larger than previously anticipated. We have new tools for detection and prevention. And so the scope of cardio-oncology certainly is growing and of growing importance. Also, the type of toxicity has changed over time with a better knowledge of how to prevent and detect these events. And for this, it's not only measuring ejection fraction by echocardiography, but coupling this with measurements of other parameters. And finally, this new discipline, if I may say, is emerging depending on the collaboration between cardiologists and oncologists for the best care of the patients. Thank you very much for being with us today, and have a good end of this meeting. Bye-bye.
Thank you.
Thank you.